Hi and a very good evening all of you. So today our topic of discussion will be based on oral pathology, and what we will be discussing is the following topics, which are always very confusing for most of the students. Okay, so let's understand the cementoblastoma here today, and the other name of cementoblastoma is true cementoma. So there is another which is in fact a false cementoma, or just known as cementoma, but now this has got another name called periapical cemental dysplasia. Okay, then we're going to understand a very similar lesion radiographically, which is hypercementosis. Another very similar, which is condensing osteitis. Now this is a form of osteomyelitis known as chronic focal sclerosing. So sclerosing is a very important term there. Osteomyelitis. Now there is chronic diffuse sclerosing osteomyelitis. So this is focal sclerosing, and we have got diffuse sclerosing osteomyelitis. Then we'll be discussing peripheral cementifying fibroma, which is a soft tissue lesion. Now a similar hard tissue lesion is a cemento-osseous fibroma, or you can simply call it a cementifying fibroma. So when it is peripheral, it is soft tissue. When it is simply cementifying fibroma, it is a hard tissue lesion. Now there's a big controversy in relation to these two lesions, okay, which is not yet sorted. So we'll be looking into that too. Majorly not for learning, but yes, you have to understand the terminologies out there. Okay, so let's start as usual with the questions. You all know that we start with the questions so that you understand some very basic background, able to differentiate between these lesions, and then we'll go into the theory part. Now this is going to be a little long lecture and will be needing multiple sessions if you want to master it. But yes, in this session I'll be giving you a very background information which is key for your NEET MDS exam. Okay, so let's come to the questions one by one, as you know, and then we'll be discussing the key points, answers, option, why we selected those options. Then we'll go to the theory part. Okay, so the first question they're talking about, read very carefully. The first question, a 22-year-old patient. So it's a young patient with a painless swelling. Okay, painless swelling in the lower jaw. Now all these are first thing is we have to identify the key point. So this is not a key point. People, what they do is they read it multiple times. What is painless swelling? What is lower jaw? Wait, okay. Radiographs revealed a well circumscribed radiopaque mass. Again, it's a vague thing surrounding the root of mandibular first molar. So still you are not able to identify the key point. Everything mandibular first molar, lots of lesions are there. Okay. Now with a thin radiolucent line, now this is going to be the key point. Okay, with a thin radiolucent line out there, the root outline is affected. Okay, the root outline of the tooth appears to be obliterated. Now you haven't seen these two things have you seen this? If you have learned the things carefully, you might not have seen these things in many lesions. So these are two very important key points. And what is the diagnosis? So now see, if you come to the radiographic picture, this is the radiolucent line they're talking about, and if you look very carefully, you will see that here the root outline is also obliterated. Okay, so these are two very important key things which you're talking about, which you have to identify. Okay, now let's come to the key points out there. Okay, the key points here, as I've told you, it's going to be a well circumscribed radiopaque mass. Now this is not actually the key point. The key point is, more importantly, with the surrounding thin radiolucent line. That's the key. Okay. Now again, an obliteration of the root outline, and it is on the mandibular first molar. So two things which should come to your mind, or which should click your mind, is radiolucent line and root outline obliteration. Okay, now you go to the option. Don't come to a conclusion, or don't think that which is that lesion, which is that lesion. No, the answer is there in front of you. Okay, out of these four. So right away jump to the option if you can't come to a conclusion, if nothing clicks. Okay, it can be either of these four, isn't it? It can be either severe hypercementosis, it can be condensing osteitis, the other name of chronic focal sclerosing osteomyelitis, benign cementoblastoma, or periapical cementoosseous dysplasia, which is the other name for cementoma. So now definitely you need to learn them, then only it will click, isn't it? Blindly it won't click. So basically it's a description for benign cementoblastoma. Radiolucent line, obliteration, typical, very, very typical. We'll come to more details. Very typical. These two features are very typical of benign cementoblastoma, besides it being occurring in mandibular first molar. If you see one of these lesions, which is basically cementoma. So this is cementoblastoma. Cementoma is periapical cemental dysplasia, which we commonly see it in the mandibular anterior. So basically here, this benign cementoblastoma is seen in mandibular first molar. Okay. And besides that, it's a rhodiopaque mass. If you come to this periapical cemento osseous dysplasia, mix it, radiolucent rhodiopaque. We're going to come to that. Okay. Now, if you go to the second question, this is many times very familiar. Now, why am I discussing this is, see, recently there has been lots of questions in this region. Okay. So, it's very, very, very important that you understand these differential diagnosis or clinical discussions. Now, here, let's come to the next question. A 45-year-old African American. The moment African term comes, there are some very specific lesions, okay, which should come to your mind. In fact, okay, again, the luckiest part for you is that it is there in the options. Okay, presence for a routine dental checkup. Okay, came for a dental checkup. Radiograph of the mandibular anterior region. That's a very key point, because not too much lesions are there in the mandibular anterior region. Okay, I'll give you in the end of this, comprehensive batch students, I'll give you a list of lesions, very common lesions and their locations, okay, in the end. In case even if I forget, please remind me, okay. Once we do with all those revisions, everything, then I'll give you, otherwise it will not enter. Anyway, shows multiple small, well-defined radiolucent radiopaque mass, okay. It's a typical picture out there, mandibular anteriors, you can see there. Yes, you can see radio-opaque a little bit, radiolucent a little bit, okay. Of vital teeth. Now, this is very, very, very important. We'll come to the non-vital things very soon. The patient has no pain or discomfort, meaning there is asymptomatic. So, basically, what's the key point going to be here? African American woman, very, very, very important key point. Mandibular anterior region. Now, I'm sure many of you have already known this answer because this is a very common question. Vital teeth asymptomatic. Now, if you jump to the option, if you see to the option, you'll see that it can be either cementoma, okay, which is periapical cemental dysplasia, which is actually the answer. All these features comes to that. Benign cementoblastoma we saw, it is not the answer. There is no thin radiolucent line. It's not mandibular, molar. There is no root obliteration. If you just see carefully this here. See, there is no root obliteration here. Root can be okay. I'll just remove that. Okay, if you just see, there is no root obliteration. Very carefully, if you can see, there is roots outline. Okay, this is the root outline you can see there very clearly. Okay, if you just zoom in, there's a root outline seen. So there is no root obliteration. Radicular cyst, periapical cyst. What is the speciality of these two? These are non-vital. So the only two vital options are cementoma and benign cementoblastoma. Okay, so of which definitely now you know what is the answer. The answer is very, very clear. It's cementoma, or the other name for cementoma is periapical cemental dysplasia. Okay, now if you go to the next question, now this is also very important, a little long question. Now this is what consumes your time. Okay, so please note, whenever you come across these type of questions, don't even read in the first round. It will never enter it. You will never be able to come to a conclusion. Okay, so let's see what this is talking about. Okay, now this is now the age is slightly at a upper age limit, 60-year-old male with a well-controlled type 2. Now this is just consuming a time. Okay, presence with a dull persistent ache in the lower jaw. Okay, let's see where the key point comes, particularly in the mandibular molar. So you saw there is many lesions there. Discomfort has been gradual in onset. All these are now, see, all these are symptoms of a particular disease, but now you can't come to a conclusion by simply reading all this. Okay, has persisted over several months, radiographic. Now, what I've seen is or personally when we also wrote the exam in our first attempt and we were not very confident and all, during that period we used to read this, we used to make this mistake. So it's basically learning from our mistakes, learning from other toppers' mistakes, you're getting this advantage. Now, radiographic examination reveals a diffuse patchy sclerosis. Now this is a key point. If it doesn't click you, it's okay. Patchy sclerosis, okay, diffuse patchy sclerosis in the mandibular molar region, again with a cotton wool appearance. Now it should be very clear. Now you don't need to go into all cotton wool appearance which are there. No, jump into the option, see which one has got cotton wool appearance. Okay, now in the image as shown in the image below. Now see, this image is very I would say very vague in fact. Okay, you can see, you can't see a proper cotton wool appearance here, but I'll show you another image. Okay, this one. Yeah, this is a kind of, patchy sclerosis out there. Okay, more better option here. Okay, with a kind of a cotton wool here. Now see, all these are, imaginations of radiologists. Okay, so you have to be that imagining radiologist for you to be identifying. But they are not asking you to identify from the radiograph. They are very clearly saying you that it's cotton wool appearance. So that's enough for you. Okay, characterized by blend of radiopaque, radiolucent lesions. Again, it's not very evident unless you know the lesions there. But the key there is cotton wool appearance. Okay, no evidence of periapical pathology. But yes, if you're a very enthusiastic learner, I'll be teaching you to differentiate between that. Evidence of chronic periodontitis. No caries, but there is periodontitis. Okay, that's basically they are talking about a type of osteomyelitis here. Focal and diffuse sclerosing, a type of sclerosing osteomyelitis. Focal and diffuse. Focal, please understand, focal is based on carious lesion. Diffuse is based on a periodontal lesion. Okay, so basically I've already told you the answer, but let's come to the options and things out there. Okay, now what are the key points you have to note here? Mandibular molar, now though lots of lesions are there, but for this particular lesion it has to be mandibular molar. But more importantly, diffuse patchy sclerosis, cotton wool appearance, very typical of chronic focal sclerosing osteomyelitis. Okay, now as I've told you, chronic focal sclerosing. Now see, you don't need to imagine all those cotton wool appearances. Go to the option, see among this which has got. Okay, focal cementous dysplasia, which is cementoma? No. Okay, diffuse sclerosing, yes, if you know it. Focal sclerosing, no, focal doesn't have cotton wool appearance. Okay, we'll come to that. Cementoblastoma, never. So basically it's diffuse sclerosing which has got cotton wool appearance, and basically it's related to periodontitis. As I've told you, focal sclerosing is related to caries. I'll come to that. Okay, so which is very typical that, as I've shown you here, the cotton wool appearances. So the answer is very clear now. Okay, basically it's cotton wool appearance. Now if you come to the final question, final question for today, which is actually a soft tissue lesion, which is shown in the image there. Okay, 15-year-old girl presents with a painless growing mass on gingiva. Okay, now it's very clear now, peripheral. Okay, but anyway, let's see. Gingiva between upper left canine and lateral incisor. Now this is again a good location, but again, you can't say that absolutely this is pathognomonic like your periapical cemental dysplasia. It can be seen anywhere, but again, a very common location. The mass is well circumscribed, approximately 1.5 centimeter in diameter and of similar color. So you can see there a similar color and location, mass, everything. With slightly reddened areas, an excisional biopsy is performed, which revealed globules. Now this is very beautiful description of the lesion. Revealed globules of calcified materials in a soft tissue lesion, closely resembling acellular cementum. Okay, now cementum, osteoid tissue, bone. So soft tissue lesion with cementum, osteoid tissue, very typical of what? Very typical of the, jump to the option C. What you can see out there, it's focal cementosus dysplasia. It's basically that it's not a soft tissue lesion. Cementoblastoma is not a soft tissue. Peripheral cementifying fibroma, this is a soft tissue lesion. But now very identical lesion, cementous fibroma, Okay, basically it also has got this histopathological appearance of cementum-like material, all those, but it's a hard tissue lesion, it's not a soft tissue lesion. So once again, jumping onto the key points, what they're talking about on gingiva, on maxilla or mandible. So it's not, this is one which differentiate these two lesions. Okay, peripheral cementifying, cemento-osseous fibroma, two fibromas. Okay, we'll come to all those fibromas, don't worry. So cementifying fibroma and cemento-osseous fibroma. So basically, cemento-osseous fibroma is more common in mandible. Peripheral cementifying fibroma, which is a soft tissue counterpart, it can be seen on maxilla or mandible. But here they are talking about in mandible. Sorry, they're talking about in maxilla, which is more common location. Similar color to mucosa, cementum-like materials, absolute. Soft tissue lesion, cementum-like material, don't confuse. Don't confuse. Jump to peripheral cementifying fibroma, which is the answer. Okay, peripheral cementifying fibroma. A little bit more, I'm just saying, which is a lesion exclusively on gingiva. You can't see it anywhere else. It can be seen in maxillar mandible. But now, it's not cemento-ossifying fibroma or cemento-osseous fibroma. Okay, it is peripheral cementifying fibroma. Peripheral, the key word there. Okay, it is not cemento-osseous fibroma because, what is that? Yeah, no bony involvement. That means it's a purely on gingiva. Though histologically you see some bone, I'll come to that question also. There's a question they asked there. Okay, no bone involvement as such, not on mandible. That's typically differentiating these two lesions. Okay, so that is all about these lesions and differential diagnosis. Okay, now we have to go into details of it. You understood? Now we'll see one by one. Okay, each lesions one by one we'll be discussing. So let's come to the diagnosis of each type of lesions we have discussed so far. Then we'll go on to the further details. Okay, basically diagnosis. Once again, it's a kind of a review kind of thing, but a little bit more in detail. So we'll be discussing cementoblastoma first. We'll be understanding the nature, the clinical features, histopathology, radiograph. Okay, the key features only. Okay, and how you treat it. Now, treatment part again, a question has been asked between cementoblastoma and cementoma. How do you treat? Very different, both of it. Okay, so let's understand the nature of the lesion. It's basically a benign odontogenic tumor of functional cementoblast. Basically, it's a tumor of cementoblast, and that's why it's known as true cementoma. It's okay. Whereas cementoma, which is periapical cemental dysplasia, which I'm going to come to that, it is not of cementoblast. It's a fibro-osseous lesion. Okay, it's a fibro-osseous lesion. Means to say the connective tissue becomes fibrous and osseous. Okay, like your fibrous dysplasia, the connective tissue component undergoes fibrosis and ossification. That's fibro-osseous lesions. But here it is purely a tumor of cementoblast. Okay, now clinical features, already told you a few very important things, that is, it comes under age of 25. It's a young patient majorly. Even your cementoma also young, but when it comes to your osteomyelitis type and all those, it becomes a little older. Location, mandibular molars. Okay, mostly first molars. Okay, so this is basically, we already saw this lesion, isn't it? I'll come to the radiographic part. So it's a molar. Okay, tooth vitality is vital. Please note here, tooth is vital. Now histopathology, yeah, this is what I told you. It's a cementoblastoma. So there should be cementum-like tissue with reversal line. That means it's a true cementum. Now why am I saying this? True cementum and all. You come to the fibromas. That is cementifying fibroma, peripheral cementifying fibroma, cemento-osseous fibroma. You'll see that there is no reversal lines. There will be only cementum-like materials. Okay, so this is actually true cementoma. That's why you see the reversal lines, because reversal lines are seen only on the true cementum, your actual cementum on your teeth. Okay, so that's very important feature there. Now radiographic, the most important identifying feature. We already saw whether circumscribed radiopaque mass. Okay, I'll show you once again with a surrounding thin radiolucent line. Yes, very important feature. And obliteration of root outline. Okay, obliteration of root outline. Now basically, obliteration of root outline is due to root resorption. Okay, so it means to say this lesion can cause root resorption, cementoblastoma. Okay, and what happens is that this fuses with the root. This lesion fuses with the root. Okay, now if you see this picture out there, very, very clear, very typical. This is a radiolucent outline, and you can see that there is no, if you just see this area, I'll just zoom it out. Yeah, there is no root outline visible. Okay, the root outline is not visible because it has undergone resorption and it has fused with the lesion. Okay, other lesions will come to which doesn't show such features. Now, in hypercementosis, now we are going to differentiate. Okay, in hypercementosis, what we see is tooth outline is distinguishable. We'll come to I'll show you the picture there. Okay, root outline is distinguishable. But now, just to give you a differentiation, one more thing is that there is no radiolucent line. So this is one very important feature between hypercementosis and this lesion. Another thing, in PCOD, what is that? Periapical cemental dysplasia. It is not the polycystic ovary disease, PCOD. Now here, radiopacity is not in the molar region. It is in the anterior region. One, and there is no obliteration of roots again. Okay, and there is no radiolucent line also. Okay. Now, another thing is, how do you differentiate between this condensing osteitis, or which you call it as focal sclerosing? Basically here, in condensing osteitis, there will be a caries lesion. Here what we see, the tooth is vital. Radiopacity is there in the bone, please note. There is no root involvement, I'll show you. Here basically everything comes out of the root. It's basically cementum. There, osteomyelitis is a bone lesion. It's not a tooth lesion, though the cause is caries. So radiolucent lesion is in the bone and not root. Okay, radiopacity is there in the bone. Okay, we'll come to more details of this, but just to give you an identifying feature, very clear. This has to be very, very, very clear. Okay, guys. Otherwise, it will never get into your brain. Now, treatment part, extraction. When you come to cementoma, no treatment. This is cementoblastoma. Cementoma, which is true cementoma. Cementoblastoma is true cementoma. Other is cementoma. So this is extraction. There you don't need to treat. Okay, it just goes away. Now, that is what cementoma or periapical cemental dysplasia. Okay, other name is periapical cemental dysplasia, where again the tooth is vital. Okay, but it's a fibro-osseous lesion, a type of cemento-osseous dysplasia. Okay, not fibroma again. Fibroma is the last thing. Not osteomyelitis also. It's a dysplasia. Tooth is vital. You see mixed radiolucent radiopaque lesion again. Okay, because it's a fibro-osseous dysplasia. Fibrosis, connective tissue undergoes fibrosis, ossification. So this radiolucent becomes radiopaque. So that's why it's mixed. Very, very, very important feature. I'll come to the details of the different types of cemento-osseous dysplasia. There is periapical, there is florid-osseous, like that. So, but yes, let's understand this first. It's a mixed radiolucent radiopaque middle-aged black woman. Typical. We saw that. Mandibular anterior, and there is no root resorption, there is no radiolucent line, there is no obliteration of root, nothing like that. The key here is majorly, you have to differentiate here. Okay, one more point is missing out there. Okay, fibro-osseous lesions of the jaw, definitely. But now basically the treatment also varies. Here the treatment, it's a self-limiting kind of lesion, no treatment is required. Whereas here you have to cementoblastoma, you go for extraction. Okay. Now the location is important. Again, mandibular anteriors. Okay, black American woman. Gigantiform cementoma. So basically it's a cementoma's modification, or it's a benign fibro-osseous lesion again. Okay, which is a type of cemento-osseous dysplasia, PCOD we said, or cementoma, which is gigantiform, again seen in black females. But you see it multiple, there's a feature there, differentiating. Multiple irregular, often lobular radiolucent. So the maxillar mandible. Now, where did we saw cementoma? Mandibular anterior. This can be maxillar mandible. Okay, often crossing the midline. So that's why it's called gigantiform, very severe kind of feeling. Distributed symmetrically and more molars, not anteriors. Okay, so please note here that the radiolucent lesion is not fused to the root. Again, there is no root obliteration. It's all features of cementoblastoma. Basically, gigantiform cementoma is a cementoma. Okay, what is cementoma? This one. Which is basically changing its location, more severe, crossing the midline, can go into the maxilla, can cross the midline, okay, and get distributed symmetrically. That's the only thing. Now, this is not a very important lesion, just for you to differentiate, okay. Hypercementosis. Now, this is very familiar lesion for you. Basically, this is it's basically excessive growth of cementum, unlike the tumor of cementoblast. Okay, simply more cementum is coming. Okay, excessive cementum growth on the tooth root. It's not a destructive lesion basically. Cementoblastoma, which is a tumor, it's a destructive lesion. That's why we saw the root outline is obliterated and all. Here there is no such problem. Excessive growth of cementum on the root, a reaction to stimuli like inflammation, trauma or anything like that. Okay, basically trauma. Now clinical features again, multiple tooth can be involved. Tooth is vital. Very typical. Young people. So all these are very similar to cementoblastoma except that radiolucent line, okay, and tooth destruction or radiograph. That's what I'm coming to. Radio opacity surrounding the tooth roots, but unlike cementoblastoma, please note here, the root outlines remains distinguishable. So I'll show you the image and there is no radiolucent line. So if you just come to this image out there, okay, this is what they're talking about. The root outline is very clearly identifiable here, isn't it? If you just zoom it out, you can see the root outline is very clearly identifiable. Okay, it's just that radio opacity. Okay, there is no radiolucent halo also, unlike your cementoblastoma. It's a very clear picture out there. So that's all about your hypercementosis. Now, the two types of osteomyelitis. Quickly, I'll just come to that. Focal sclerosing and diffuse sclerosing osteomyelitis, two types. Okay. So focal sclerosing osteomyelitis, again the same methodology will go. Basically, it's a type of osteomyelitis, okay, which is a reaction to carious lesion. Caries is there, and a sclerotic response. Why sclerotic response is important here? Basically, if you have an osteomyelitis, what happens? Destruction. It destroys the bone rather than reaction. Okay, actually the lesion kills the bone. It's not the bone or kills the lesion, or it's not the bone reacting to the lesion. Actually, the bone is destroyed. Okay, destructive lesion. But here it is sclerosis, bone responding to the lesion. Basically, it's young individuals and it's a response to carious lesion basically. Okay. Now, clinical features, I'll come to the radiographic, very important. Tooth is non-vital because carious lesion progress to the teeth. Now, see, so far we were discussing all those were vital. Now, this is non-vital. Associated with carious lesion, often asymptomatic because sclerotic, younger individuals, understandable. Now, radiograph increased the radio opacity because it's sclerosis, okay, well defined in the bone adjacent to the roots, okay, of the affected tooth. But the tooth itself is not involved in sclerosis. That's where you identify with all those lesions you were talking about previously. The root is very clear out of everything. Okay, I'll show you the picture out there. Okay, so if you just come here, okay, this is very typical, isn't it? You can see the PDL, root is not involved. The PDL is very clear there, isn't it? The PDL is very clear. And you have the sclerosis here, which is separated from the bone. Just see this. Sclerosis is very separated, it's not bone, it's from the root. Okay, but there is a carious lesion. Okay, you can see this. This is the carious lesion out there. Very clear carious lesion out there. This also again sclerosis, very well differentiated. You can even see a radiolucency, periapical radiolucency, because if there is periapical inflection, but again it doesn't say that it's a radiolucent hollow around the lesion. It's not around the lesion. It will be around the root. That's also possible, but here's a clear differentiation. The root is, okay, stands separate, okay, and there is a carious tooth, majorly mandibular first molars, okay. You can see this picture there, which again, as I've told you, it's first molars only. So this is very clear. Okay. Now, if you see that was about focal sclerosing. So if you come to diffuse sclerosing, again it's an osteomyelitis. So one is focal, other is diffuse. That's the only difference. We'll come to that. So basically it's same as focal, what they're saying, but the first one, the cause was majorly caries, very limited. Periodontitis is very extensive. So the lesion is also extensive. So that is, okay, basically it's due to periodontal origin. Now, see, focal is always caries tooth origin. Diffuse is not always periodontal, it can be other traumas also, but periodontitis has been identified, one of the factors. Extended to a large area, okay, beyond the affected tooth. So that's what it is, diffuse. Okay, and again, we saw focal was in younger individuals. This you will see in older individuals. Okay, like the question we had, an aged person. Okay. Now, when you come to the radiographic appearance of diffuse sclerosing, as I've told you, it's a cotton wool appearance out there. That's sclerosis, giving the cotton wool appearances. We have already seen that. Okay, please note, it's different from your chronic suppurative osteomyelitis, which gives that mottled and moth-eaten. That is chronic suppurative. This is chronic diffuse sclerosing, which is cotton wool. I'll come to the osteomyelitis in detail, where we'll be discussing those mottled and moth-eaten as well. Okay, so I think I'll end this session by that. Okay, that will be the end of this lesson. Now a quick review of whatever we said so far, because recently I received a review from the students saying that this is very useful. So I'll quickly go through that. So basically, cementoblastoma, that radiolucent line, root outline is obliterated. Okay, you can see that picture there. Then cementoma or periapical cemental dysplasia, mandibular anterior, very, very black American woman. Okay, very important. Mandibular anterior, mixed radiolucent radiopaque. Chronic diffuse sclerosing. Now, chronic focal sclerosing was, see this picture there. Yeah. There is sclerosis, typical sclerosis, but localized to the tooth, carious lesions out there, and you also see that it's completely separate from the root. Okay. Whereas if you come to the diffuse sclerosing osteomyelitis, it's diffuse sclerosis, so more area being involved rather than, okay, see this, I don't know, okay. Yeah, the more area being involved here. Okay, this is very typical. Now, whereas the last lesion, which I have not went into any detail, as a soft tissue lesion with cementum and, what? Bone-like tissue, but there is no reversal line. Cementoblastoma, there is reversal line, which says that it's a very typical real cementum. This is not real cementum, it's just a cementum, something which is looking like cementum. Okay. Okay, so that will be the end of this session. So thank you so much. Have a good day. Take care.